Welcome to UMedics, a health learning platform. Primary survey in emergency medicine. It is the initial assessment of the critically injured patient, aiming to identify the life-threatening conditions and simultaneously manage. The life-threatening conditions can be clinically diagnosed and confirmed by investigations, and so when identified during primary survey, should be managed simultaneously. The 6 life-threatening conditions are airway obstruction, tension pneumothorax, open pneumothorax, flared chest, massive hemothorax, and cardiac tamponade. The primary survey follows the ABCDE approach. A. Airway maintenance with cervical spine protection. Assessment. Check for airway patency. Is the airway patent? Talk to the patient to see if he or she can respond or talk. If yes, the airway is patent, and if no, the airway is not patent. The causes or the things that can obstruct the airway: when there are secretions in the nose and or mouth, any mechanical foreign body, oral and or nasal, the rolling back of the tongue, any facial, mandibular, tracheal or laryngeal fracture, any head injury that affects the neck or the cervical spine. And always assume cervical spine injury if there is multi-system trauma, especially with altered level of consciousness or with blunt injury above the clavicles. Management: if airway is impaired or affected, adjust head position, head tilt, chin lift or jaw thrust maneuver to establish and maintain airway, and also to visualize the airway. Immobilize the neck to prevent further injury. Maintain the cervical spine in a neutral position with hand or manual immobilization, which is necessary when establishing an airway. After establishing airway, immobilize cervical spine with appropriate device such as cervical collar. Also suction the mouth and or nose to clear secretions if present. Suction mouth first before the nose. Remove any foreign body as oral or nasal, and oropharyngeal or nasopharyngeal intubation for any rolling back of tongue to prevent tongue from obstructing the airway, then manage other underlying causes or conditions. B. Breathing and ventilation. Assessment: is the breathing intact? Check if patient's breathing and ventilation is intact. General inspection: expose the neck and chest. Is there any rise and fall of the chest? Check respiratory rate and depth of breath. For respiratory rate, count over 30 seconds to 1 minute. Normal respiratory rate is 12 to 20 breaths per minute. Check oxygen saturation, which should be above or equal to 95%. Inspection, palpation, percussion or auscultation of the chest. Inspect and palpate the chest. Is there any use of accessory muscles such as the sternocleidomastoid muscle? Any signs of injury? Any crepitus? Any tracheal deviation? Asymmetrical chest expansion? And percussion: is the percussion note resonant, dull or hyperresonant? Then quickly auscultate the chest. Air entry should be adequate, vesicular breath sounds, and no other sounds. You note that airway patency is not equal adequate breathing and ventilation, and so breathing and ventilation should be assessed even or if airway is patent. The causes: some of the conditions that can impair ventilation: the life-threatening conditions, tension pneumothorax, massive hemothorax, open pneumothorax, flared chest with pulmonary contortion, and other underlying causes. The life-threatening condition should be managed simultaneously to prevent any death, organ failure, or disability. And management: if breathing and ventilation is impaired, manage. So with the management, elevate head end of the bed to about 45 degrees. High flow of oxygen through narrow rebreather if oxygen saturation is low or patient is in respiratory distress, evidenced by nasal flaring, use of accessory muscles, and others. Consider mechanical ventilation Back and valve marks if patient is gasping or not breathing. Request chest X-ray to confirm clinical diagnosis or no underlying condition. Also, arterial blood gas can be requested, which shows markers for oxygenation and ventilation. Then manage life-threatening conditions. Any life-threatening condition confirmed after chest X-ray. For tension pneumothorax, needle decompression or place chest tube. For open pneumothorax, seal opening with sterile dressing or a Sherman chest seal placed, then needle decompression. Proceed to C, that's the circulation with hemorrhage control. For circulation, how well the body is being perfused. Assessment, is there good circulation? Look for signs of shock. Check pulse, the radial pulse, carotid and femoral pulse. Check the rate, the rhythm, volume and character of the pulse. Normal pulse in adults is 60 to 100 beats per minute, regular rhythm and of good volume. Check blood pressure, which should be below 120/80 millimeters of mercury and above 90/60 millimeters of mercury. Capillary refill time, which should be less than 2 seconds. The skin color, is patient skin pale or cyanose? Check peripheries, is it warm or cold, which is always cold in shock. Also look for any hemorrhage or bleeding, either in the chest, abdomen, retroperitoneum, pelvis, long bones. And check the jugular veins if they are distended. Then quickly auscultate the chest for heart sounds. First and second heart sounds should be present with no murmurs. Causes or conditions that can affect or impair circulation. External or internal bleeding with hypovolemic shock, massive hemothorax, cardiac tamponade, and shock. Management, if circulation is impaired, secure intravenous access with 2 large bore cannula. Oxygen therapy, when circulation is affected, patient oxygen saturation can be affected. Adequate fluid resuscitation with crystalloids, such as normal saline, Ringer's lactate solution. Give 1 to 2 liters intravenous bolus in adults. Hemorrhage control, apply direct pressure on external bleeding site or dress wound to stop bleed. And blood transfusion if indicated. And also, if there is cardiac arrest, CPR should be done for the patient. Investigations. Some of the investigations that can be requested when circulation is affected. Electrocardiogram. Take blood samples for full blood count and cross-match, group and cross-match. Then pelvic X-ray in case of pelvic fracture, which can cause significant blood loss. Then quickly manage life-threatening conditions such as cardiac tamponade, massive hemothorax. For cardiac tamponade, Beck's can be used to diagnose where there is hypotension, jugular venous distension, and muffled or diminished heart sounds on cardiac auscultation. Also, Kussmaul breathing when there is a rapid, deep, and labored breathing, and also pulsus paradoxicus. For cardiac tamponade, pericardiocentesis is done. For massive hemothorax, there is a rapid accumulation of more than 1,500 ml of blood in the chest cavity. The signs the patient can show, that's hypoxia, absence of breath sounds, and or dullness to percussion on one side of the chest. And the management is thoracostomy. Disability or neurologic status. Check level of consciousness. AVPU followed by Glasgow Coma Scale for more in-depth look. For AVPU, is patient alert? If patient is alert, meaning level of consciousness is normal. V, does he or she respond to vocal stimuli? If patient does not respond to vocal stimuli, there is mild impairment. P, does patient respond to painful stimuli? If no, there is moderate impairment. Then U, unresponsive to all stimuli, which means there is severe impairment. Also, Glasgow Coma Scale can be used for more in-depth look into the level of consciousness of patients. Using a pen touch, check pupils, the size and the responsiveness, which should be equal and reactive to light. Check glucose level and ensure it is at normal range. The causes or factors that can affect disability or conscious state of the patient, as when there is decreased cerebral oxygenation, when airways and or breathing is affected, the conscious state of patient can also be affected. And 2, when there is decreased cerebral perfusion, that's when circulation is affected or impaired, the conscious state of the patient can also be affected. And metabolic and or neurological causes such as alcohol, drugs, or hypoglycemia can affect disability, specifically the conscious state of the patient. Management: intubation, pass NG tube when Glasgow coma scale is less than 8. Administer intravenous mannitol 1.5 to 2.0 grams per kilogram body weight in a head injury and also conscious. Pass urethral catheter to monitor output. Arrange for agent head CT scan, especially in an unconscious patient secondary to acute head injury. And always rule out hypoxemia and hypovolemia first, then manage underlying conditions such as any metabolic or neurological cause. Exposure or environmental control. Assessment: fully expose patient but ensure to maintain dignity of patient. Check the temperature, which should be within 36.1 degrees Celsius and 37.2 degrees Celsius. Any head injury or burns, if there is any, calculate the total body surface area bend and also the depth of the bend. Management: take patient from source of injury, then protect from hypothermia by placing in a warm room or use of warm intravenous fluids, and maintain pneumothermia. The primary survey is a systematic approach to assessing and managing critically injured patients. By following the ABCDE approach, healthcare professionals can quickly identify and address life-threatening conditions, improving patients' outcome and reducing morbidity and mortality. I hope this session sounds fun and educative. Kindly like, subscribe, and share, and put us on post notification.